Good afternoon, everyone. Welcome. My name is Winnie Armand, and I am an Associate Director at the Massachusetts Center for the Environment and Health, Massachusetts General, and a physician in the Division of General Internal Medicine. Thank you for joining our monthly Grand Round webinars about climate, the environment, and health, covering a range of topics related to mitigation, adaptation, and advocacy. This is a joint effort co-sponsored by the centers at Mass General, Brigham and Women's Hospital, and the Institute of Health Professions. It's my privilege to introduce you to an esteemed speaker today, Dr. Paul Biddinger. We have been so fortunate to have him at the helm at Mass General and at the state and national levels, leading us through numerous threats. Dr. Biddinger is the Chief Preparedness and Continuity Officer at Mass General Brigham. He is also the Director of the Center for Disaster Medicine at Mass General and the Director of the Emergency Preparedness Research, Evaluation, and Practice Program at the Harvard School of Public Health. Dr. Biddinger serves as a medical officer in the National Disaster Medical System in the Department of Health and Human Services. He is an active researcher, lecturer, and author, and has responded to numerous disaster events, including Hurricanes Katrina and Sandy, the Boston Marathon bombings, the Nepal earthquakes, and many, many others. And you might be asking yourselves, how does he have any time at all? He completed his undergraduate study in international relations at Princeton University, attended medical school at Vanderbilt University, and completed his emergency medicine residency at Harvard. What an honor to have him here with us. Thank you, Dr. Biddinger.
Well, thank you so very much, Dr. Armand. It's really a pleasure to join you and to join everyone. Thank you for the invitation. It may not make sense to some of you why I'm here speaking about climate change or about environmental issues from the perspective of a disaster planner, disaster responder. And hopefully by the end of the hour, I'll make it a little more clear, but I think not only is climate change directly threatening human health, as we'll touch briefly on, but I think most everyone is very likely deeply aware, but it actually threatens the infrastructure that we need to deliver healthcare services. And I think we really need to make sure that our healthcare system is not only aware of the health threats of climate change, which again, I think are familiar to everyone here, but also we are adequately preparing the system to withstand the effects of climate change, that when we need the healthcare system most, it is still delivering care, and that's what we'll touch on. So I have no conflicts to disclose financially related to this presentation. And what I want to do is briefly touch on how climate change threatens human health. Again, I think probably particularly this audience, you're all aware of the threats in much more detail than I'll present them here. But it's a huge deal, and it's an ethical and moral responsibility, I think, for those of us in healthcare. But it's also a practical consideration that if the nature of the illnesses, the volume of the illnesses that we're caring for is changing, that we have to anticipate this. We have to put it into our capacity planning and our health system planning. It is obviously extraordinarily important for us to reduce our environmental footprint within healthcare. And I won't be touching really directly on it, but I know you've had other speakers speaking about this, and it is so important. Obviously, the White House climate pledge, is one great example of how healthcare system must be working to decrease their own contributions to climate change. But really the majority of what I'd like to focus on is what climate change means for the preparedness of healthcare systems, what we need to be doing, and I'll go through an example of what I think is a way forward for how healthcare can do this through what we've been doing here at the Mass General Brigham system in Boston. So again, I think I'm very much preaching to the choir on this one, but the Lancet has called climate change the biggest public health threat of our time. I think we are all incredibly aware of the ever-growing body of literature that talks about the adverse health consequences of climate change. And so again, if anyone on this webinar is not already familiar with the Lancet's work, led by my colleague, Dr. Renee Salas, who does such an amazing job, but by so many other people, by the US Climate Resilience Toolkit. Again, there are a number of academic repositories of the studies and summaries of the studies that talk about how climate change is affecting human health overall. And this is just kind of a simple schematic of really, what we're looking at is, of course, we're seeing, and we'll go into this in more detail in a second, but the increased temperatures. This is a particularly salient week to talk about temperature extremes, but precipitation extremes, others. And all the myriad ways in which these climate change consequences are affecting human health. So it's affecting how we use land for agriculture and for human habitability. That affects ecosystems and frankly, the infrastructure of the human habitable portions of the planet. It affects the livestock and the animals that we both live with and depend on as part of our food supply. Everyone is aware that climate change is not equitable in how it takes a toll. It is absolutely having disproportionate effects on poorer and more vulnerable communities. We are seeing this again this week in Europe with the tremendous heat wave that they are seeing, that the elderly, the poor are more suffering consequences, including death from the heat wave that we see from a lack of access to air-conditioned spaces, lack of ability to get to respite spaces when needed, et cetera. And overall, of course, it's increasing stresses on the quality of our air, the air we breathe, the water we drink, the food we consume. There are lots of infectious disease threats. I spend a lot of my time working on zoonoses, on the diseases that come from animal populations into human health. And climate change is really increasing pressure on zoonoses. We're seeing changed range of animal populations, which changes likely where we see new diseases. Everyone remembers the Ebola outbreak of 2014-15 in West Africa, where Ebola had not been seen in West Africa before. We are now seeing Marburg, or related viral hemorrhagic fever, that now is also poking into West Africa with a couple of cases. And as we see fruit bats or other animals changing their geographic range, there are reasons, unfortunately, to believe that we will see some of these diseases changing their footprint. And so again, I expect most all of you are quite familiar, at least in concept, with this, if not much more with the data specifically about it. But this is all making us sicker. This is increasing our cardiovascular illness, our respiratory illness. It makes overall outcomes from those that have exacerbations of COPD or other illness, makes their outcomes worse, especially in times of temperature extreme and others, and has even mental health consequences and stress. So all of these factors really do mean that anyone who's planning for healthcare delivery, not even just disaster medical services, but healthcare delivery, that these are all stressors, meaning we will have more demand for healthcare services. We will need to deliver more healthcare directly because of climate change. So that's listed on this first bullet, but particularly to me, as someone who plans for disasters for a living, I'm actually especially worried about additional things, which is when disasters happen, and we'll go through this in just a bit, but we know, you all probably are quite aware that we're seeing more frequent hurricanes, more severe hurricanes, more severe precipitation, et cetera. During each of these events that are becoming more frequent and more severe, we have to continue for a population that is more ill, and we have to preserve our ability to care for those who become ill because of the disaster. Excuse me. So we have to care for those who are newly sick and injured in a hurricane or in a flooding event. We have to make sure that the hospital doors stay open so that we can continue to care for those in our communities who need our care otherwise. And when other services in the community fail, particularly power-related services, we have to be able to care for those who depend on us for life-saving medical care, like durable powered medical equipment, home ventilators. Those who are at home with a ventilator, if their backup power sources fail, often healthcare facilities turn into places of refuge for those who are most critically ill, but otherwise living in the home community. And I would expect some of you are familiar with the concept, but within healthcare, we are continuing to care for more and more and more people at home, and not in long-term care facilities, not in acute care hospitals. And we're expanding our home health services, our visiting nurse services. This means that when we, again, have power failures, have other disasters affecting a wide swath of the community, healthcare facilities need to be resilient so that they can be that facility of refuge, that facility of last resort for those for whom other community services are failing. So that's really important that we do that. You've seen the consequences of what happens, obviously, in Hurricane Katrina. We had the failure of Charity Hospital, damage to Tulane Medical Center. In Superstorm Sandy, you're familiar with the evacuations of Bellevue and NYU Medical Center, and the consequences, right? That you know, entire tertiary care medical centers have needed to evacuate. 700 patients evacuated from Bellevue, a lot in the middle of the night, down stairwells with no light, no emergency power, no power of any kind, and then hospitals or communities left without hospital services for a long period of time. There was no emergency medical care available in Midtown Manhattan and South for months after Superstorm Sandy. And these ongoing consequences of loss of access to healthcare are very significant for communities. So hospitals have to become more resilient. I think there's an imperative for healthcare to become more resilient, given what we know is happening with climate change. You cannot do this alone. As much as I try desperately to make the facilities that I'm responsible for as independent as possible, it is not possible to make us fully independent of the communities that we're in, from a power, telephony, internet, access to roadways kinds of issue. So we have to work together with other community partners as well. But, you know, I'm disheartened by the fact that there was a relatively recent study that said only 20%, basically 21% of hospitals have looked at their healthcare assets from a climate perspective. So only 1 in 5 have even looked at how vulnerable they are to updated flooding maps, updated heat stress maps, what roadways they could lose due to climate change that would affect access to their facility, either the ability to receive patients or the ability of staff to access their facility and work there. Just as one example, and you know, you've seen what has happened in the general Houston area, where they had such severe flooding just a few years ago with Hurricane Harvey. But there are currently still to this day, 770 hospitals, utilities, and water treatment plants that are at risk of flooding bad enough to basically take them offline. So completely stop power generation, water treatment, and healthcare. 770 different facilities just in one county in Texas surrounding Houston. And there are thousands of hospitals across the United States who do not know what their climate vulnerabilities are because they have not looked. And this is, I think, one of the most important changes we have to advocate for within healthcare. So how do you assess this risk? How do you figure out how vulnerable you are? How do you approach the question? For anybody who does know emergency management, there's a very basic concept we have in the emergency management world called the hazard vulnerability analysis. Any healthcare organization in the US that has CMS funding, funding from the Centers for Medicare and Medicaid Services, has to do a hazard vulnerability analysis and update that on an annual basis. The way we try to do it is to look at 3 different components of risk. Many of you may know we're not very good as humans typically at assessing risk. We focus very much on one thing and we're really able to ignore a whole bunch of others. This is why some people really hate to fly and prefer to drive, even though the absolute risks of injury or death are very different, as you know, for that. So we have to really look at how likely are events to happen. And we have to look at it with as much clear-eyed data as possible. Some people have very skewed perceptions of how likely an event is or isn't to happen. If the event happens, what is the consequence? So how severe is the damage to my community, my healthcare facility, to my nurse and physician and other healthcare workers' homes? Can they come? Can they respond to work if it happens? What happens for demand in the healthcare system? Who do we need to care for? And then there's a third component that a lot of people don't think about, which is existing preparedness. So how ready are we for these kinds of things? If there's a flooding event in my community, how protected is my hospital? Do I have deployable flood barriers? Do I have sandbags? Have I hardened my facility so that it's resistant to flooding? So only if we take a look at each of those three sets of variables for probability, consequence, and preparedness can we actually say what our risk really is for the consequences of climate change or any other threat that we face. However, one of the big faults, I think, of emergency planning in the United States for healthcare is that we use a lot of historical data. People tend to, it's actually often talked about as a best practice to look back and see what you've experienced in the last 1 year, 5 year, 10 years, 30 years. And what we know is that every year we learn how bad historical data is for future planning when we think about the climate. So we have what we called affectionately called Snowmageddon here in 2015, where we got almost 9 feet of snow in a 4-week period. The Louisiana floods of 2016 are notable because that was precipitation related flooding. That was a storm that basically set up shop and did not move and dumped an enormous amount of rain, far greater than has ever occurred in the area outside of Baton Rouge, causing many, many different long-term care, acute care hospital facilities to need to evacuate. And it reflects not just an increased severity of storm, but how climate change is changing what we see, flooding in areas that have never flooded in the past. So historical data really being useless in terms of assessing flood risk. So I'm going to go through this pretty quickly because I think this is data everyone is in concept familiar with. But what are we seeing as a result of climate change? Well, it's more temperature extremes, more maximum temperature extremes, and an increase, frankly, in the mean and the variance of these events. And again, all you have to do is look at what's happening in Europe this week to see it. But there are similar scenarios playing out in India and Southeast Asia, to the point that certain parts of South and Southeast Asia are really at the edge of human habitation because of temperature extremes. Increased coastal flooding. Again, this is due to sea level rise as well as storm surge from events, particularly hurricanes or cyclones, depending on where you are in the world for what you call them. One of the classic unfortunate stories of the limited utility of historical planning comes from Superstorm Sandy. So NYU, after seeing what had happened in New Orleans during Hurricane Katrina, NYU had built 13-foot flood walls around their power generation equipment in the basement. They said that, gosh, if there's a storm surge, we looked and did the very best estimate we could historically of how bad the storm surge could be, and that led them to build a 13-foot wall. And the storm surge they experienced in Superstorm Sandy was 14.5 feet, and that's what flooded their electric equipment. That's what took the entire power for the hospital offline and made them need to evacuate the entire institution. And so bad historical data about how bad the flooding can be in your area can lead to some very significant, very real consequences. I mentioned that it's not just coastal flooding. I think sometimes there's a bit of a smug reassurance that, gosh, if I'm not on a coast and I'm not going to have a hurricane come get me, the flooding risk is really not that bad. And I think, many of you saw that although Hurricane Harvey was in fact a hurricane, the vast majority of its consequence for the Houston area was just the prolonged duration of the rainstorm, of the flooding, nothing to do with any storm surge at all. It really was just precipitation related flooding. And when you look at the center of the country, particularly the southeast of the country, but it really goes almost all across the country, across many of the seasons, depending on where you are. The Northwest is in the best shape, but the rest of us are at risk of significant increased precipitation. Wildfires are a direct climate threat. We've been seeing actually more hospital evacuations as a result of wildfires than we ever have seen in the past. And they move incredibly quickly. They are particularly challenging for hospital emergency planners because you get very little warning. They go much faster than hurricanes, which we at least have a few days to look at when they're happening to determine whether we need to evacuate or not. Cyclones or hurricanes, again, different words for the same phenomenon. Everyone's pretty much aware that both frequency and severity are rising. Of particular consequence is the Hurricane Harvey phenomenon, where once hurricanes come ashore, the models suggest that they're going to actually stay longer. They're going to move more slowly over communities and therefore dump much more water on those communities, raise the flooding risk. Tornadoes, again, something that is not coastally related at all. We are seeing increased frequency and wind speed severity of tornadoes. And you have to look back at the Joplin tornado in Missouri that took out one of the two major medical centers for a huge portion of Missouri, and took it offline for years until it was able to reopen. Again, the facility was completely destroyed. So, 2017 is kind of a recent-ish poster child for what happens. But if you look at just in 1 year alone, it was a record-setting year for the number of billion-dollar, with a B, billion-dollar climate-related disasters that happened. And unfortunately, I think it's not going to stay a record-breaking year for long. We just continue to see more and more and more events that are not just hurricanes, but hurricanes, tornadoes, flooding events, others. So with all the doom and gloom, data that I think feels pretty familiar to everybody, what do we do about it? That's where I think it's really important that the healthcare system has to start thinking of itself differently. This is not a terribly new concept. There's a report that's almost a decade old now from 2014 from the Department of Health and Human Services. It says we need to start taking this into account. They put together actually both a report and a nice planning toolkit for healthcare facilities to start thinking about what climate change really means for them going forward. It makes the same point that I made earlier, which is, first off, don't consider community infrastructure to be invulnerable. Assume that you may have power outages, you may have steam loss, you may have roadway disruptions. It really emphasizes how important it is to harden healthcare facilities, either through retrofits or renovations, or certainly when you plan new healthcare facilities to be able to plan differently for how you construct them. It emphasizes that it's not just the building. We have seen obviously tons of supply chain shortages that have been exacerbated through the COVID pandemic. But supply chain issues are very, very real in climate related, in environmental disasters. Roadways and supply lines, even warehouses can be really significantly disrupted. And what that means is that healthcare facilities have to have much more of an assumption of independence for the facilities, the food, the water, the other essential items they need physically on site in their campus when they're facing disasters. This goes directly against every trend in healthcare emergency management otherwise, where we are going to just-in-time delivery and having almost no warehouses of anything on our campuses. So most modern healthcare systems have a 3-day or less supply of almost everything that is a consumable medical need, and they get resupplied every 1 or 2 days. Some hospitals get supplied multiple times per day, including some in my system. And so the idea is, if you lose your access to the supply chain, if you just can't have the trucks come to you because you've got flooded roadways near you, if the warehouse that has those supplies, if it's destroyed in the storm, if there are other needs, you don't get resupplied for 7, for 10, for 14 days. You can't deliver medical care after 3, 4, 5 days. And that's extraordinarily important planning for healthcare institutions to take on, is figure out what they're going to do about supply chain disruptions that are related to climate change. So we need to be designing resiliently. We need to be designing green, again, to reduce our contribution to climate change. For those of us that have academic programs, for those of us that are research hospitals, it is common, unfortunately, to forget about the whole research arm in all the rest of the work that you're doing. So people, when they focus on this, do focus on clinical care. That's important. That's great. But there are lots of stories of research animals, research data, research laboratories being destroyed and really setting back the pace of medical progress by years. There's an old Nova special, the TV series on PBS from Hurricane Katrina that has a very poignant anecdote that shows healthcare researchers from New Orleans canoeing across the streets of New Orleans to try and save tissue samples from a brain tumor that were donated by a researcher who unfortunately died of that disease in their lab. if they had lost those samples, those were the only ones in the world that they were able to do research on, and really irreplaceable knowledge and the ability to improve human health through research. So something we have to consider, and actually surprisingly few research facilities still have considered. So as I mentioned, there's a toolkit that goes along with the report, and there are lots of good resources in there. If you haven't seen it, or if you're in healthcare emergency planning, encourage you strongly to take a look at it. There have been other things that have come out since 2017 when that was last modified. But I would argue, and I guess what I'd like to argue here, is that every healthcare institution, every healthcare organization in the country needs to be taking this question on very actively. Just as we are looking at our active shooter, armed intruder plans, as we are because of the unfortunate worsening violence that we're seeing across the country, this is an urgent issue for us. But there are a lot of obstacles to change. Depending on where you are in the country, depending on what system you work within, there is still some skepticism about climate change projections that needs to be addressed. There is such a wide range of potential events and consequences that makes it hard to have a good conversation, right? When you're talking about, are we preparing for a 100-year flood, a 500-year flood, a 1,000-year flood? And what does that even mean? Which data are we using to make those projections about what's a 100-year, 500-year flood? If we're using old data, that those terms probably don't make as much sense. And then, healthcare is cost constrained, and so trying to figure out how to make this a cost-effective argument for your CEO, for your COO, CFO, for your board of directors is really, really hard. So I will tell you that I'm really, really pleased. I'm proud of the fact that my own healthcare system has taken this extremely seriously. And what was successful for us? Well, it was successful in agreeing on a set of data projections and data assumptions. We did have to have some hard conversation with leaders across the organization about what were the plausible projections, what were the acceptable sources of data, and what was the risk tolerance we were trying to address with making sure that our healthcare facilities would be able to deliver healthcare in time of a disaster. Once we had those data assumptions, we were able to go out and look at examples of what has happened in the healthcare sector from climate-related events, helps us quantify what is going on. And then when we look at losing X hospital or X Y number of hospital services, that helps us be able to actually quantify the health and the business impact of those scenarios. That lets us ultimately write down a list of vulnerabilities based on those assumptions, and we can prioritize our action items. We can prioritize how we go about that. So I will take you through what that means. That may have been a little too high level or vague for some of you, or for everybody. And so let me make it a little more concrete. Let me describe what we actually did. So again, I work at Mass General Hospital. I oversee the emergency preparedness program of Mass General Brigham. Mass General Brigham is a not-for-profit healthcare system in New England. We have 16 different member organizations, acute care hospitals, long-term care facilities, a lot of urgent care, community care, many other kinds of healthcare services. We are the primary teaching affiliate of Harvard Medical School, and we are the largest hospital-based research program in the United States. We started taking this on really shortly after Katrina and then robustly after Sandy. So after Katrina and thinking a lot about climate change, I'm pleased to say we've had a lot of leaders across our organization think about climate change for a long time. We took lessons from seeing what happens when hospitals are knocked offline, designed Spaulding Rehabilitation Hospital, which is a hospital we have here very near to Boston Harbor, and designed it as a resilient facility. I'll say a little bit more about that in a second. But I mentioned that we were scared by Katrina. I would say we were really scared by Sandy. You know, seeing what happened when people tried to take action for climate change and their assumptions didn't quite work out, and they still had to evacuate. They still lost services. That made us need to say, okay, we're going back to the drawing board. We're going to try and find the best climate projections we can so that the data on which we're making our planning assumptions are good. We're grateful, we're fortunate that both the city of Boston, where we have many of our facilities, city of Cambridge, just north of us across the Charles River, we're also doing municipal climate assessments and engaging scientists and other researchers to try and come up with forward-looking projections. And the goals of our project were to come up with a set of assumptions about climate risks. Once we know what those risks are, how bad are the storms or other threats that we're going to face, where are we vulnerable, where we're vulnerable, what does it take to respond to those vulnerabilities, and how do we remediate against the vulnerabilities we've identified. So we did it as a three-phase project. The first, as I've already said, is to come up with a set of assumptions. So we looked at sea level rise and storm surge. So overall, as sea level rise worsens, again, we're right on the coast here in Boston, where would we have routine flooding? And in severe storm scenarios like hurricanes, where could we see maximally bad flooding? We're seeing a lot of precipitation as well. And so we have what we call riverine, what everyone calls riverine flooding, that comes from the opposite direction. So the ocean is to the east of us, but most of our rivers flow from the west towards the east. So we can actually see riverine flooding coming from the opposite direction as storm surge flooding. We're definitely seeing increases in temperature. We are seeing increases in wind speed. And I will say, I acknowledge that seismic change is not in fact climate related. But since we were bringing engineers and scientists together, we actually threw seismic risk in the hopper since we have a number of buildings that are quite old across our system. So we came up with assumptions about what were the real worst case scenarios that we think we could face. I'll talk about timeline in 1 second, but looked at those scenarios. And then we looked at every single one of our buildings that delivers healthcare. And we said, okay, for each of these scenarios with this amount of flooding or this precipitation or these wind speeds or this temperature, what is likely to fail? Where are we vulnerable? And we came up with a very, very long list of more than $300 million worth of remediation activities. And you know, there is no way that immediately we can possibly fund $300 million worth of remediation activities for climate change. So we had to prioritize. So we sat down with our individual buildings and grounds engineers, our facilities leaders. We had to look at the consequences, we had to look at the probability, and we had to come up with a capital investment strategy that over the long term will make us more resilient. It very much applies to every new building that we build across our system. But even every time we do renovation, we do an update, we have capital for improvements, this overall master blueprint is considered. I mentioned that I would talk about 2 different timelines, and I think that really is important when you think about how you're going to approach climate change within healthcare. You know, climate change is gradual, obviously. It takes a long time. We're really not talking about weather change, but climate. And so the scientists that we had working with us had said, basically, you know, we should choose windows that have kind of the right error bar on either side of them. So we chose a 2030 scenario and a 2070 scenario. And what is most likely for climate change in each of those scenarios could happen, give or take, within about 15 years of each of those time windows. So we're already essentially in the 2030 scenario. The reason we have 2 different scenarios is that we will not be able to rebuild all of our physical infrastructure in the short term. Obviously, that's pretty obvious. So a lot of the stuff that we identify as risks in the short term scenario, we're going to have to develop emergency operations plans for remediation. So we need to see where we improve our hospital evacuation plans, or where do we need to purchase new deployable flood barriers for areas that are vulnerable to flooding and we just can't make the building hardened fast enough. 2070 is more the new construction, the long-term capital planning. So if we assume that our new buildings have at least a 50-year lifespan within healthcare, that everything we build from this day forward should be resilient against what we think the climate change consequences will be by 2070. We do not want to build any more healthcare infrastructure that has vulnerability still in 2070. And we need to think that far ahead when we're thinking about the different climate risks. Was key to be multidisciplinary. This definitely doesn't work only if it's the emergency preparedness team talking about the risks we have. We worked with our financial leaders, our long-term capital planners. We worked with our facilities engineers, our real estate office. We worked with our risk and insurers because this is very directly relevant to a lot of the insurance programs we have for the services we deliver for the hospitals we have. And then we tried to basically look at 3 different buckets of vulnerability. So just from a facility perspective, where might we not be able to do ambulatory care or emergency care, surgical care? You can see everything listed in green. Of the services we either sometimes generate ourselves or often get from the community, whether that's power, whether that's natural gas, whether it's delivery of medical gases, you can see everything listed in blue there. Where are we vulnerable? And we tried to dig pretty deeply into, again, not just our own vulnerabilities, but our supplier vulnerabilities. For the company that delivers us oxygen, what are the scenarios by which you might not be able to give us oxygen, and how long, in a worst case scenario, do we have to plan for resilience? For our steam providers to give us heat, sterilization of medical equipment. What, again, could disrupt our steam service, and for how long could that go? And then continuity issues. We really recognize that even if the building is secure, it's hardened, our staff have to be able to get to it and go home from it in order to be able to live their lives and care for their families. Our patients have to be able to access us. A hospital is not a hospital, and we do transfer patients around every day for reasons of acuity or other reasons. And so how easily is it that we're going to be able to normally move patients around from a community hospital to a tertiary care center for a sick or complex patient, other directions as well? These are all important continuity considerations. So once we created those buckets, we looked at it again from those lenses of operations, facilities, continuity. We then got the results of the study, and I would say that in general, as you would expect, that the results are pretty disheartening. On average, when we first did the study, and now it's been a few years since we first kicked off this study, on average, the Boston area gets about 7 to 10 days that are greater than 90 degrees. In the near term, the 2030 scenario, which again, statistically includes even 2022, where we are now, we're getting up to 30 days per summer greater than 90 degrees of heat. And unfortunately, by 2070, the entire summer, basically 90 days of greater than 90 degrees temperature is what we're projecting. I'll tell you that none of our healthcare facilities are built for that kind of heat stress. The equipment doesn't have that kind of power for cooling. We depend on the evenings getting below 70 degrees for some of our HVAC management strategies. And it's telling that the vast majority of our cooling capability across the system was not even on emergency power when we first started looking at these issues. So if there were a big blackout, brownout in the New England community, we lose emergency cooling. And that obviously quickly makes a hospital uninhabitable. That's true for the vast majority of healthcare infrastructure in the Northeast. And it tells you what the consequences could be if we had a Northeastern brownout in the near term across the healthcare sector. So we really looked at how quickly can we change that? Can we make our cooling services disaster resilient? What chillers do we have to add so that we have greater cooling capacity? What redundancy do we need for emergency power? We have been building in basically giant electric plugs on the sides of some of our buildings so that we can pull up emergency power generation trailers, basically generators that look like 18-wheelers, to be able to support the cooling capacity. And of course, how can we make our buildings more resistant to heat gain when needed? We looked at wind. Boston's a slightly windy area given the fact that we're on the coast, but the projection is by 2070, we will be facing Miami-Dade speed wind speeds during certain storm events. That means that our hospitals are really vulnerable. That kind of wind can take a window off, can cause extraordinary water penetration during storms that can threaten your electrical, threaten the integrity of your building. And even though building code does not yet require it in our area, we are designing all of our future new buildings to Miami-Dade speed wind speeds because again, this is what we think we may face by 2070. We have to look at our roofs. Lots of stuff can blow off the roofs, especially communications equipment. A lot of our cooling equipment is actually up on the roofs. And so we are working very hard at the ballasting, at the overall structure resilience of the equipment that is essential on our roofs to make it resilient against these new wind speeds. Flooding, probably that's the one that occurs most to everybody is the flooding risk. And I'll tell you, my own hospital, which is sort of down here in the lower left-ish center, Mass General, it's at significant risk of flooding. We are at the junction of the harbor coming in very close by. We are separated by a flood gate. But then in that lower left, you see that's the Charles River. So we're kind of on both sides flanked by harbor and by Charles River. And there are a number of circumstances where the water comes around us. By 2070, some of our basement areas are at risk of flooding. But even more concerning is we quickly become an island. It's pretty easy for 360 degrees around us to be water, and that creates, of course, huge access issues. So as we look at sea level rise, as we look at riverine precipitation coming from the other area, we have been absolutely forced to look at purchasing deployable flood barriers, looking at how we harden utilities in basement or other services that might flood. And how do we work with our own utility providers and others in the community to advocate for improvements. I will also tell you that we did learn some interesting and concerning things about flood risks of other healthcare organizations in our area, that they actually are also at risk of flooding. In fact, they're at greater risk of flooding than we are. And we've had to share some of these projections with them because it's not clear that they necessarily knew they were at risk of flooding to a degree that will take them offline. On top of that, I will tell you that we are learning more and more that building management is becoming increasingly automated. And so power outage, computer, internet outages create new kinds of building concerns for us because you potentially lose those building control systems, which are essential for, again, your cooling, your HVAC management, et cetera. I will say in the medical research sphere, the -80 freezers are a particular bane in my existence. They're often not even on emergency generation capability. The alarm systems for them used to be a lot more heterogeneous if they existed at all. And we've been working a lot over the years with our research leaders to try and get these -80 freezers. These are the storage freezers that store those essential samples to get them on backup power, to get them appropriately alarmed so that animal habitats, others are protected as much as our human care capabilities during disaster. So last couple of things, sheltering in place is a term that most people hadn't really heard of until a few years ago. Now, I think more and more people have heard of it, but as we're looking at the overall resilience of our facilities, there are a couple of additional considerations. If there were an industrial release of chemicals, if for some reason the ambient air were to be unhealthy, as we adjust our HVAC systems for climate change, we're looking at how we can quickly protect them so that we don't take in extra outside air. With every new building we build, I've talked a lot about supply chain already. We've looked at how can we convert, say, a parking garage into an emergency warehouse so that if there's a hurricane coming up the East Coast, we can stock up 3 to 5 days of additional durable or disposable, medical supplies and have an on-site warehouse. And for a new building that we will be building very soon, we are building in basically submarine doors to the below ground facilities so that we can bring in a lot of medical supplies for disaster, keep them protected against flooding and other risks, and basically make sure that our newest infrastructure is resilient for at least a week, no matter what the resupply capabilities are. We look, since again, we're looking at facilities for other things that are not climate related, but are important, the security, access to our facilities, again, the unfortunately changing threat of violence in our communities that affects our hospital. When we replace glass, we don't just look at wind speeds, but for certain areas that are publicly facing, making sure that it also is blast proof so that it doesn't turn into shrapnel. We are working a lot, I mentioned zoonoses, working a lot to improve our infectious disease isolation capability. Of course, we've been going through the COVID pandemic now for the last 2.5 years, but there are other threats that require even more ability to safely isolate patients beyond the precautions we use for COVID. Expanding that capability, I think, is important, especially for larger academic medical centers. So just briefly to touch on Spaulding, I mentioned Spaulding Rehab Hospital. The design process for this lasted years before 2013, but it was very intentionally designed as a climate resilient hospital. It was designed to look forward 70 years in terms of climate change effects, as I already mentioned. And the good news is that doing all the resilience changes you see here on the screen, and I won't read them out to you, but only added between 0.3 to 0.5% to the overall building cost. So really not that much. And combining those resiliency adaptations with green building has created a 30% reduction in the energy use, and the operational savings from those green changes has more than offset the cost of making it a climate resilient building. And I can't tell you how important I think it is for healthcare facilities to do this. We will be building a very large new building with more than 400 patient rooms here at Mass General in the coming years. And I'm extraordinarily proud of the fact that it's designed as both a green building, but also as a resilient building. Those 400 beds are built with double head walls so that, we're a 1,000-bed hospital here at Mass General. We can evacuate at least 400 additional patients out of our less resilient existing buildings at Mass General into the new building when it's built, so that we are a climate resilient, disaster resilient facility. So what do we need to do? And I'll stop at the end of this and see if there are questions or other comments people would like to make. But I think we have to continue to look in the emergency management world at climate change and look at what it really means for the delivery of healthcare services, for the demand for healthcare services. I think all of us have to be advocates to combat climate change. Again, it absolutely directly affects our ability to care for patients, which is the mission of what we do. I think we within healthcare have to have our own house in order. We have to ourselves be reducing our contribution to climate change. We have signed on to the White House Climate Pledge, and I'm so proud of so much work that's been done across our system, but many other systems to do that. This has to be a core part of your facilities, your expansion, your overall real estate and capital investment plan. And you need to come up with a strategy yourself, if you're in a healthcare organization, to be able to figure out when you renovate your building, how you can make it more climate resilient, how you can address these threats little by little by little. There's not a hospital system, I think, in the entire country that can take this all in one bite. But we have to see this as a threat. We have to see this as a vulnerability, and we have to have a rational, database, evidence-based way of approaching our climate risks in a way that year by year by year we get less vulnerable, more resilient. So I will stop there. Again, I want to thank you for letting me join you. Really been a pleasure. And let me know what questions there are.
Thank you, Dr. Biddinger. That was really insightful, informative, a little depressing, but hopeful at the same time. I think it's hard not to be depressed, particularly right now when we're seeing such disaster globally at this point. As we're waiting for questions to come into the chat, I wondered if you could speak to discussions around staffing contingencies, if that's something that's been brought up in the discussions.
Yeah, no, thank you so much. I think there are several really important discussions about staffing contingencies. I think, Gulf Coast hospitals in the US, other places around the world are used to the idea that you have to shelter staff with you for a few shifts when you have an anticipatable disaster, right? So when a Category 5 hurricane is bearing down on Florida or Georgia or Louisiana, they're used to the fact that they have to bring in, at least one, if not two shifts worth of doctors, nurses, administrative staff, others, to stay there because access to the hospital and to the community may be interrupted. I would say increasingly we've been working on those kinds of plans across the whole country, certainly across my healthcare system. We have the ability to house a couple hundred staff, within our hospital to make sure that 2, 3, 4 days we have, at least dual 12-hour shifts that can stay here and staff. I think increasingly in the Gulf Coast, but even up here in Vermont after Hurricane Irene, we've learned lessons that you also have to support your staff at home. Hurricane Irene in Vermont, some of you may remember, it hit New York, then it kind of came up inland, and there was huge flooding in Vermont, especially in the mountains. And so many of the healthcare workers there had really devastating damage to their own homes that the healthcare workers couldn't stay 3 days straight at the hospital. They had to go home and rip out the drywall in their basement, take care of their partner, of their children, of their elderly relatives. And I think, you have to, as a healthcare system, acknowledge that people have lives outside of the hospital and they're going to have needs after a disaster that are very, very important. And so thinking about how you set up your shifts, what kind of short-term support might you need, even including emergency loan programs for disaster home renovation to support your workforce, I think are really, really important considerations. The last one is the hardest, which is, as you well know, in healthcare, we're all suffering a tremendous staffing shortage right now. And we have people leaving healthcare. We are all incredibly strained in the staff we have. I think trying to make sure we understand what that means for our disaster preparedness is a really important challenge for us right now. There just aren't waves of, especially nurses, but really anyone in healthcare who are on the sidelines able to come in during a disaster and help bail us all out. We kind of have who we have, and we have to figure out how to use our staff appropriately. So we've tried really hard to learn lots and lots of lessons about staff redeployments and how staff have been used through COVID-19. I think there have been successes. There have been a lot of challenges. And I think those apply not just to the ongoing COVID response, but to other disaster situations, and try and figure out when can someone be deployed outside of his comfort zone, their usual job role, and when can't they? That's important ongoing study. Hopefully we'll learn even more about.
Great, thank you. That's interesting. And just as a side note, the American Nurses Foundation is doing a series of surveys with nurses post-COVID to look at the long-term impacts. And what's a little of concern is that the younger, less experienced nurses are feeling the psychological impacts more, and a larger percentage of those people are thinking about leaving where they work or the profession. So there's a lot to consider for sure.
Yeah.
Todd asks, how helpful has the city and state government been in subsidizing potential costs of transitioning for climate impacts at the hospitals?
So I have to put an asterisk next to my answer, because there may be things that I don't know of. I think in general, there's not much direct funding available for subsidy of these kinds of changes. There's certainly, I would say, both city and state governments have been extraordinarily supportive of the concept of climate resilience. And I think, there's been a lot of work that's trying to be done at the community level to address common risks. And so there are some grant funded programs to help identify, people who are in a certain flooding basin together, what mitigation, some common mitigation strategies just to reduce community flooding. I think ultimately the challenge is these things are just unbelievably expensive, and capital renovation in healthcare costs an awful lot of money, and frankly disrupts healthcare as you're delivering it. So requires you to take some operations offline in order to do the renovation. So I am hopeful. I'm cautiously hopeful that there will be more grant programs coming, but I think for the most part this is something hospitals are going to have to do on their own, and we, even on our own, I would say, are looking at other ways we benefit, not just beyond what we've already talked about, but say through improved insurance rates, that if we can prove to our insurers that we are more resilient and we are less of a risk, there may be a potential financial benefit there.
Great, thank you. Lois says that our health system has found it helpful to connect our mission, which is creating healthy communities, when discussing sustainability and care of the earth Has your organization used this approach?
Absolutely, and I get to take absolutely no credit for this, but I think the mission of creating, supporting, maintaining healthy communities and making sure that we're doing our part to support all of that is huge. I think, we are really proud that we have really decreased our carbon footprint for our healthcare system, and we've taken this pretty seriously now for quite some time. We have reduced our emissions by 58% since 2008. We are continuing to look at how we can address emissions even further. And, we had a previous goal, which is to overall reduce our energy consumption by 25%. I'm pleased to say we actually made it harder on ourselves and said we would like by 2025 to reduce our energy consumption by 40%. And so I think those arguments are resonating for exactly the reason she mentions, that it's part of our mission. And I'm really glad to see that.
Great. I think we have time for one more question. And the question is, you mentioned maintaining access to natural gas during an emergency or disaster. Have you investigated the possibility of alternative forms of energy and getting your healthcare system to the point of not needing natural gas?
I would say yes, certainly. And we are expanding both direct as well as indirect offset measures of this. So wind and solar are a big part of what we're looking at. And again, some of our facilities have invested directly in solar. Our enterprise headquarters has a very large solar generation and generates nearly all of its own power through that. We've been creating new partnerships, expanding with offsets through wind and solar as well. And so I would say absolutely looking to move away from fossil fuels whenever possible. And when we do look at using, say, natural gas for cogeneration, which is a big resiliency strategy, is looking at how we can do that at least as efficiently as possible. Long-term goal clearly to move away from carbon-based sources whenever possible.
Great. Thank you so much. I think that's all the time we have for questions. So I want to thank you again for this very fabulous, interesting discussion. But one quick question. So when you say solar at the enterprise headquarters, are you talking about Assembly Row?
Correct.
I didn't know that. So that's really interesting to hear.
If you go up to some of the top buildings, you can see our whole parking garage and almost all of our other flat spaces are solar. Yep.
That's really cool. So you learn something new every day. So I want to thank you so much. And for those who are have joined us today, just to let you know that we are taking August off. There will not be any webinar in August, but we'll be back in September with Jody Sherman, who is an associate professor of anesthesiology at the Yale School of Medicine. She's also an associate professor in epidemiology, in environmental health sciences, and the founding program director of the Yale program on healthcare environmental sustainability. So kind of a continuation of a little bit about what we talked about today. So we hope you will join us in September. That will be the third Wednesday of September. And we hope you all stay cool and take care of yourselves and enjoy the month of August, and we'll see you back here in September. Thanks so much.